Hello, everybody. It's Bishop Megan Rohrer, and today we are having a conversation about COVID-19. In case you're watching this on archive, know that the information we're providing today is January 11th, 2022. And we have a guest who will be joining me. Would you please introduce yourself?
Yes, hello. Thank you, Bishop Rohrer. I'm Susan Phillip. I'm the health officer for the city and county of San Francisco. My pronouns are she, her, and I am so happy to be talking with you all and presenting today. I really think that the work we do is aligned. I'm focused on health. You're focused very much more broadly on the congregations you lead and participate in on flourishing. But I think that health is a small and important part of an overall flourishing life, a big part, I would say, for most people. So we'll focus on the small part related to Omicron and COVID-19. So looking forward to our conversation today.
Wonderful. Well, I know you've prepared a presentation, and so I will allow you to take it away with that beginning conversation.
Thank you so much. And thank you very much to Nika from my team who's helping move the slides. Thank you. So again, why don't we move to the first slide? So I want to frame a little bit of the numbers. I think sometimes it can seem very scary to see and hear on the news about all the cases that are happening. And when we look at the curves of the cases, it does look very startling to see the numbers of cases. So this is from the New York Times, and it's looking, starting back in 2020, at the numbers of cases throughout the United States. And we see several places where we've had surges. So the one that is in the middle and is sort of touching the line there, that's the winter surge last year. Very dark time, literally and figuratively. We had just started getting vaccines. Most of us had not been vaccinated. And it was a really frightening time to think about people getting infected with COVID-19, getting very sick, needing hospital care. And that was quite difficult. There were a lot of restrictions in place throughout California, as I know people remember well. And particularly in San Francisco, we had to really almost entirely make sure that we were sheltering in place, that we were not doing very much of anything. And in many cases, congregations were not meeting either. They were meeting remotely and not able to be together. We then saw those cases come down, and we were very hopeful that we would have ongoing ability to remove our restrictions, to be able to all meet together for worship and for many other purposes. And then we saw in this summer, in August and September, another surge, and this was the Delta variant. This was a different variant of the original COVID-19. So I just want to take an aside and say, what does it mean to have a variant? Because we're going to be talking about the Omicron variant for most of this presentation. A variant occurs because a virus, basically its whole job is to mutate. It makes copies of itself. It's trying to infect other people. And what it does is it makes more copies so that some of those copies could leave me and infect another person. That is a virus's job in life. As it's doing that, there are just randomly sometimes mutations and changes that occur in the genetic material of the virus. Sometimes by chance, those changes come together and allow the virus to potentially spread faster, make people more ill. And those are what we call the variants. The World Health Organization identifies those that have a higher chance of either transmitting, making people more ill, maybe not responding to our vaccines and treatments. So we have the Delta variant. And then similarly, just most recently, we have had the Omicron variant. And that one is so transmissible. You can really see this vertical line going up with the numbers of cases in the United States, like really much, much higher than we would have thought possible. And this is a 7-day average. So we have had some days where there's been over 1 million cases reported in the United States, which would have been unthinkable except for the speed that this virus transmits. What has been somewhat reassuring and has been really a good and fortunate thing is that our hospitalizations and our deaths so far are not taking that same vertical rise. And that's really important, particularly hospitalizations, because one of the key goals that we have in public health is to prevent the most severe disease, to prevent our hospitals from being overwhelmed with people that are seeking care and then can't get it, not only for COVID-19, but say someone has a heart attack or is in a motor vehicle accident, we need those hospitals to stay open and accessible. And so we are seeing increases. Hospitals are under strain in California, but we are not seeing the same level of severe disease, which is good. Next slide, please. So I'm going to show you some data for San Francisco. I am responsible for health policies and health orders in San Francisco. And I know that for many of you, you're outside of this county, but I'm going to use San Francisco as an example just for our data. And then I'm very happy to talk in conversation about other questions people may have. So this is looking at San Francisco. Before we were looking at just numbers of cases in the US. And this is a measure where we adjust the cases we have in San Francisco for the size of our population. So theoretically, that means we could compare San Francisco and Los Angeles and New York because it adjusts for how big each city is. So we see this winter surge here. This was the Alpha variant. Then we talked about the Delta variant, and now we see the Omicron variant. So it's the same shape. It's just a different scale, a different amount, total amount. We have fewer cases, of course, in San Francisco than in other parts of the state and certainly elsewhere in the country. But the general shape is the same, the steep rise with Omicron. Next slide, please. So again, watching very closely about hospitals. Again, you see the same shape. After there's a rise in cases, generally, there's also been a rise in hospitalizations. It takes about 2 or 3 weeks for the virus to make the people that are going to get sick will get sick enough with the virus in their lungs, get pneumonia, get other complications and need to go into the hospital. So we usually see that 2 to 3 week window. So right after we saw the surge in the winter, we saw the hospitalizations go up. After the cases went up in the summer, we saw the hospitalizations go up. With Omicron, we are not quite seeing, we do see an increase, but we don't quite see the same level. And some of this is related to vaccination and boosting, which is not 100% protective against infection, but it is, if you are fully vaccinated and boosted, it is very protective. It is the best protection you can have against having to go into the hospital. So we are hoping, and we are watching closely to see if cases and hospitalizations are not going to be linked in the same way in Omicron as it was during the earlier surges. And that has important implications for how we adjust our policies for public health as well. Because again, we're trying to prevent the most severe disease and to save lives. Next slide, please. So again, I'm responsible for San Francisco. It's very helpful for me and for others in policymaking to look at our maps and to understand where are the areas that have the highest case rate. So if you look at this map of San Francisco, the darkest blue is where there's the highest case rate per 10,000 residents in that neighborhood. So again, allows us to compare across neighborhoods. And what we have seen from the earliest part of the pandemic is that these cases are not distributed equally in San Francisco. And I bet wherever it is that you live, that is the case. And we can understand that, economic situations, people that have to keep going to their essential work as grocery store clerks, as drivers, they were not able to shelter in place and do their work at home. They're at higher risk. We know that racism as well as other factors keep people from being able to have their healthiest lives. There are other issues as well. People who are LGBTQ also have challenges with the structures, the homophobic, transphobic, and anti-LGBTQ structures that make it challenging, again, to have a healthy, flourishing life that I know you all have as part of your core mission for everyone, all of our neighbors to have. So we are focused on making sure that we can understand the highest rates. So some of you who know San Francisco might wonder why the marina is lighting up. This is a relatively wealthy, and in terms of population, there are proportionally more white people here than in other parts of the city. And some of this has to do also with vaccine uptake and somewhat lower, quite frankly, among people who are self-reported as white in San Francisco versus all the work that community leaders and faith communities and the San Francisco Department of Health in the city have been doing with many other lower income communities. But we're all connected, as you all know. And this is starting to sound like a message you all would deliver. But COVID has really shown us how connected we are And we can only be healthy if all of us are healthy. Next slide, please. So, to that end, our main goal is to get as many San Franciscans vaccinated and boosted as possible. So we have a new way of thinking about vaccination. We are talking now about being up to date on vaccination, and we're increasingly probably going to be hearing this from the CDC and from the state California Department of Public Health. So up to date means that not only have you gotten your primary vaccine series, so that is 2 doses of either your Moderna or your Pfizer vaccine or 1 dose of your J&J, but also if you are eligible to get a booster, you have gotten it. So that becomes increasingly important because having that booster, again, is the highest level of protection that you can have against COVID-19 infection and against serious disease and hospitalization. So when we look at all residents here, we see that 88% have gotten 1 dose, 81% have completed their overall first vaccination series, and 58% have gotten their booster. And from what we know, even with all the cases that we have, our best chance of having this virus not cause as many people to get severely ill as it could otherwise is to make sure this booster rate is as high as possible. So there are many teams, both from the city and from other organizations and health systems, that are working to make sure that residents have access to boosters and to their first vaccines if they haven't had those yet. Look at this age group of kids 5 to 11. And, this is the group that most recently has gotten access to vaccines. And in San Francisco, 67% have had a first dose and 54% have completed their vaccinations. Keeping kids in classrooms is such an important goal. And I know that is a concern, whether you're a parent, a family member, a friend, or just a resident in California. We really want our schools to be open. And having these kids have these protective vaccines is an essential part of doing that. Next slide, please. Oh, sorry. Before you do that, Nika, could you go back to one slide? I just also want to show that, we break out the residents that are 65 and older and 75 and older because those individuals, if they do get infected with COVID-19, tend to have more severe disease. And we want to especially make sure that they are as protected as possible. And so a lot of the early focus, a lot of the intensive work has been to make sure that those individuals are as boosted as possible. So they are at 78% for both of those age groups, which, we're happy with, but we keep pushing to go further. Next slide, please. And, we spoke a little bit about how COVID is not distributed evenly. And so for equity, our response cannot be distributed evenly either. What works for the people that have the most resources and the most ability to wait in line or to, make your appointment and leave work because you've got paid sick leave it's not what's going to work for a single mom or a person that has to work their job. They do not have the ability and time because they're taking care of other family members or they have other responsibilities. So it's been a key strategy to partner with community organizations that know their neighborhoods and their communities best to understand how do we deliver a vaccine. And that could be, weekend events. We have heard that in some neighborhoods, they want it to be a party. They want music and they want food, and that's what brings people in. So we have really learned important lessons. We should have known this all along, but it really brought it into contrast that communities know best, and we have to work with communities. And we try to provide the technical expertise, and in many cases, the vaccine and the people to do the vaccination, and communities really help us as trusted partners. Community organizations are trusted partners within communities, and that has been, part of our strategy. So we have really focused on Latinx populations, on Black African American populations, to try and increase rates of completing the primary series. And now we're moving on to boosters as well. And you can see some of the numbers there from our most recent data. Next slide, please. So, in thinking about the state overall, there also is not an even distribution around the state. Like all public health is local. So it's important to kind of understand the levels of transmission in the counties in which you might be living and working with and serving others. So, you can see here, actually, the Bay Area has some of the higher rates. We do quite a bit of testing, and the more you look for, the more you find with COVID-19. So that is contributing to some of it. But again, it is such a transmissible virus that we'll talk a little bit more about the virus itself, but just so you could take a look at the map and see the variation. And then, throughout the Bay Area, we work very closely with the entire region, the Bay Area region, and are always thinking about our policies. It's better if they're kind of in unison. It doesn't make sense if you live in one county and work in another county to have to think about all these different rules. So we try as much as we can to be uniform. But, the considerations in the Bay Area are very different than in Southern California or in the Central Valley. And so that's where a local health officer makes those decisions for the county, for their counties that they work in and serve. And I should have said to beginning, what is a health officer? Well, it's a state mandated position. So every county has to have one. Some cities have one, and of course, San Francisco is a city and a county. We have to be unusual that way. So that is and the health officer has legal authority to basically make health orders, which are laws, which are legally binding, in order to prevent disease and illness. So throughout the pandemic, that has been a big focus of us as health officers throughout the state.
When you look at these numbers, are there numbers, like when people are looking at the rates in their county or the ICU numbers, are there specific numbers you would recommend congregations look at when they're trying to make a choice about whether to be in person or online? Because it seems like these are the two criteria they normally look at.
They do. I think that both of those can be helpful at times. Looking at your own local county public health and seeing if they have recommendations, even if they don't have a rule that says that you can't gather, often they will have some indication that, it's recommended or consider or, other ways. And thank you for raising that. We will talk about some practical things that congregations can do to think about making choices that might be safer and considering the people that may not be vaccinated, maybe too young to be vaccinated, or may have underlying medical conditions that we need to think about. Next slide, please. All right, so let's talk a little bit about Omicron. I won't spend too much time, but I think it's helpful to understand why is this so different? Like, what is up with this strange virus that is so easy to spread? So if you remember, it feels like a lifetime ago, but it was first identified in South Africa and Botswana in November. The thing that I always like to remind people is that South Africa has a state-of-the-art surveillance system for variants, better than the US. And it was identified there because their scientists and their epidemiologists are so good, not necessarily because that is where it originated. So I think that's very important to remember. The World Health Organization called it a variant of concern. So as I said, variants happen all the time. It's just random. Sometimes they can be detected, something new. Scientists have global networks where they look at the sequences and they kind of say, this seems unusual, it seems different. This one, we'll look at it a little bit more closely, seemed different enough and had some mutations that in other variants had been associated with either being easy to transmit or maybe having some concern that a vaccine may not work as well, that they called it a variant of concern. This is basically the World Health Organization saying, let's keep an eye on this one because it has the potential to spread or to cause other problems. So this one is dramatically different from the previous one. We showed you that surge in the summer. That was the Delta variant. And this is an outdated slide, sorry. It was previously the most dominant variant worldwide. So Omicron basically shoved Delta aside because Omicron is so much more readily transmissible. It kind of crowded out all the other variants. And then the first case of Omicron in the United States was actually detected in San Francisco on December 1st. It was a very astute traveler who came back from a region of where Omicron had been detected very early on. And then we were able to work with them and with the UCSF scientist collaborators to make that identification. So it hasn't been very long, right? December 1st until now is like 5 weeks to see such a change in our epidemiology in the United States and in California. Next slide, please. So again, this won't be a big biology or science lecture, but I just want to show you. I just think that the science is so cool. I'm an adult infectious disease doctor by training, so I can nerd out on the biology and the microbiology, and I will not do that. I will spare you that. But just to say that this is different because it has a lot of mutations. And a lot of them are in the spike protein. So I think most people have seen by now a cartoon of the SARS-CoV-2 virus that causes COVID-19. It looks like a little ping pong ball with like spikes coming out of it. So you see it in cross section here. The things in the cartoon that look like golf tees, those are the spike proteins. Those are the spikes of the COVID-19 virus. And that is what's necessary to help it bind to a human receptor and actually cause infection in us. So this represents a human. This little thing that's marked ACE2, those are the receptors that it actually binds to cause infection. So if there are lots of mutations in that spike protein, a couple of things could happen. One is it could bind more easily. It could kind of like evade and kind of trick the antibodies that were looking for the Delta or looking for the previous virus. So there are multiple reasons why it might be spreading so quickly, but the evidence is clear that it does. Next slide, please. And it has happened fast. So this is data from CDC, and orange is the Delta variant, and purple is the Omicron variant. And remember, here, right, this week, this is when we saw the first case in San Francisco. And then, over time, up until the 1st of January, it, again, has just crowded Delta out almost entirely. And that's what you see on these pie charts here. We're in region 9. So you see almost all of the sequences that are done, that are evaluated in particular labs to look to see, well, what kind of variants are we seeing in California? It's almost all Omicron right now. Next slide, please. So it is definitely more easily transmitted. The good news, the very good news, because we would be having an entirely different conversation if this were not the case, it is not as severe as Delta. It seems to be maybe about half as severe. And so it results in fewer hospitalizations per person infected. So I want to qualify that. If you have a variant like Omicron that is infecting 6 times as many people, but it's only half as likely to put those people in the hospital, you still have a lot of people going to the hospital. And so that is what we're up against right now. It's not that every single case is so bad. It's that so many of us are getting infected. And we want to make sure, in areas where fewer people are vaccinated, there's a greater risk there. As I've written here in the third bullet, vaccine doses are really needed to prevent infection. And even then, there are breakthrough cases, even if you're boosted. But the cases are generally mild. You can deal with them at home. You might not feel well for a few days, but you're not going to the hospital. Just 2 doses are less effective than against the previous variants because of all those changes that we looked at in that cartoon. And recovering from infection alone is even less protective. So for people that tell me I'm not worried about it, I had COVID and I'm protected, well, not against Omicron, you're not. That is not a good thing to rely on. Another question that has come up is a question around rapid tests. So I know that it's very difficult to find these right now, but we are hearing from the Biden administration and others that sources will increase and that we'll have different ways to get them. There has been some question about, for Omicron, is it harder to detect it? Is it maybe not as accurate? It misses some infections. So what I would say with this is if you're using the tests at home, a positive test is very helpful. Trust it. In the era of Omicron, with as much infection as out there, you should trust that and not worry, oh, maybe that was wrong and I should just ignore it. If you have symptoms and you're testing and you get a negative test, that's when you need to be skeptical of the result. You would need to assume that you may be positive, isolate as much as you can from others, and then repeat the testing in 2 to 3 days. You could either repeat that rapid test because as the infection progresses, the amount of virus in your body increases in your nose and in your throat, and it's much more likely to pick it up. Or you might decide you're going to get a lab test, a PCR test, which is, the most sensitive test, but it takes a few days to come back. So the rapid tests are very good and useful. You just need to know what their limitations are and take the whole picture. You want the whole picture of what's happening around you and in your body before you decide what do you do with the test result. And then there's more and more availability of these new antiviral treatments that will be coming out. They are oral. It's very exciting. So hopefully people that might be at high risk for having a serious infection, as these become more readily available in our retail pharmacies and health systems, your doctor would be able to prescribe you a course of taking it at home. And you need to do it within a certain number of days of developing your symptoms. But then it can prevent you from getting very sick. So these will also contribute to being a game changer as they become more available. So very, very exciting. Next slide, please. Okay, so let's get to some of the practical things, and I know you all will have good questions. So what is it that you all can do as you're caring for yourselves and caring for others? I think that the biggest piece of this is encouraging vaccination and boosting for everyone eligible. That is what is going to give the durable underlying protection that we all need to get through this. And what I would say is, especially for people who are leading services, who remove their masks to be heard well, it's really important that those people are up to date, so fully vaccinated and boosted. If you can, use better masks when you're using masks. So people talk about N95s. Often those are used in the hospital, but there are others as well that are quite good, KN95s, KF94s, or this is one that I like because it's comfortable and it's pretty easy to get your hands on this. Get a procedure or surgical mask, but if you've ever worn one of those things, just the ear loop ones, you know that there are gaps sometimes at the side of your face. Take your cloth mask and use it over that, like cinch it down, especially if it's adjustable, and tighten that fit. That's the really important thing. The layers of the surgical mask are very good at preventing infection, but it just doesn't fit well enough. So you need to improve that with a cloth mask over it. And that is a pretty easy adjustment for most people to do. Right now, I would not advise just using a cloth mask. Omicron is too transmissible, and the cloth masks are just not going to cut it. So, we haven't said that they are not permitted in San Francisco, but we are definitely encouraging people to understand what's a better mask and to choose along that spectrum. Okay. And then know what your local requirements are. So in San Francisco, as I said, we have health orders in place. Masks right now are required indoors everywhere, except in worship for eating and drinking as part of the ceremony. So communion, is fine, and that is acceptable. But minimize the amount of time that the masks are removed for the majority of the congregation. So I think thinking about that as you are planning how communion is going to happen, whether you will have the congregants drink the wine, whether you'll do intinction, I think it really just depends on how can you decrease the amount of time that everyone has their mask down. Ventilation is so important. This is why, we always say outside is better than inside, because especially here in San Francisco, we have a lot of wind. There's a lot of ventilation, and it helps disperse the COVID virus particles. And, being outside in general is good. Now it's winter, it's raining. You can't always do that, but whatever you can do to increase ventilation is helpful. If you can get a cross breeze going, if it's not too cold, if you can have air purifiers in, particularly if you're in a closed area, that's something to consider. So in the beginning of COVID, I think as everyone remembers, we were really thinking a lot about cleaning. People were wiping down their groceries and their boxes from their retailers that were sending things to them. And now we know that cleaning services is not as critical. We do have to have good hand hygiene. That's true every flu and cold season. But it's not spread by surfaces per se. It is spread by people doing what I'm doing, talking and being around others. And we need to just clean per the usual, standards. People, I also want to mention, I didn't write this down here, but I know that singing is always a question. Very early on, there were documented cases, and unfortunately, people that died, that passed away at choir practice because they were all singing and they were together for hours on end. So singing is somewhat higher risk because we're forcefully, exhaling. I think the way you have to think about it is not necessarily to say no singing, but I think you have to think, are there vulnerable people in this congregation? Like every congregation will probably need to decide for themselves how to approach that. But vaccination and boosting, if masks, can be worn, that also is additional help. So you just have to think about the layers. The ventilation, again, the baseline foundation is vaccination and boosting. But then on top of that, you could layer masks, you could layer ventilation. If you can find them, you can layer testing. Sometimes I've said for the people who lead singing with their masks off in San Francisco, they might consider doing a test before going up and leading folks. So there are combinations, and I agree with what Bishop Megan had said, which is people are getting information and then they're creating a tailored approach to prevention that works for them and for their congregations, and that's absolutely right. Next slide, please. Okay, and then kids and seniors, and of course these are populations, both of whom are so valued, I know, within congregations, but also in society, and we want to make sure that they have the best protection possible. So layers of protection, again, we just talked about this: vaccines, masks, tests, and if someone is symptomatic, this is an important message which all of us can be mindful of. Do not come to church or Sunday school or small group or any of that if you're not feeling well. That is really an absolute step that we can all take to care for our neighbors right now during this surge. And that's really important. And children under 5 cannot yet be vaccinated. We are waiting. We're hopeful that in the coming days we'll hear more about that. And those that are under 2 should not wear masks, for safety reasons. They're just too little, and it poses too much of a concern for choking. And so all of us around them then must try to do what we can to keep them as safe as possible. So what's ideal then is if those who can are vaccinated and boosted, masking around them, et cetera. But it is those are the strategies that will be most helpful. And then again, families always have to make those decisions. Like, do I wait a couple of weeks before going back in person? And I have talked with families that are thinking through that. And for some children who have medical conditions or other reasons to be concerned, or their pediatrician is concerned, that absolutely is something to think about as well. Importantly, in San Francisco, we are not seeing a higher proportion of cases, even as our cases are going up and the absolute number of kids is getting higher. The proportion that's in kids is not getting higher. So Omicron does not seem to be kind of singling out kids in any way, which is good news. And we're not seeing any increases in hospitalizations among children due to COVID. There's always the issue of when there's more cases in the community, more people test positive, but we're not seeing kids ending up in the hospital because of COVID. And so we watch that very closely. The layers of safety for seniors are really the same. They're very similar. Obviously, seniors do have abilities to get vaccinated and boosted for the most part, unless there's a medical or other reason that they cannot. And so assisting them to be able to do that in whatever venues are available in your community is really a good thing to do. That is what is most protective. Unfortunately, with increasing age, even with vaccination and boosting, there is still a chance of very severe disease. So again, if people have underlying medical conditions, if their provider says, I'm really concerned that you may have a bad outcome because of your underlying lung disease or other things if you get COVID, those people may also make different decisions about the activities and the level of risk they feel comfortable with. But again, having the best possible mask, having the vaccines and the boosters, and then deciding as a congregation, as a family, as an individual, what level of risk we're willing to tolerate. We are going to be moving into a phase where we have to coexist with this virus. It's not going to be an emergency forever. And we take and accept risks all the time, getting into cars, crossing the street, all sorts of things. So we will have a better sense after this surge comes down as to how we can move forward. But I think that the way that we're talking about it now is a framework to start having those conversations, which are so important, and thinking about it. Next slide, please. And I mean, that's it. I will leave with this information, but I am very happy if we have time to have a discussion and talk a little bit. I'm happy to answer any questions or hear your input. So thank you all for your time. Oh, I think that you might be on mute, Bishop. Thank you.
Well, I'm super appreciative for all that you've shared with us, and I know that you also might have to pop off to other presentations today. Do you have time for a question or two?
I do.
Okay, so we have a question about social time after church. Should people just head home as soon as possible? Traditionally, it's been like coffee hour. I imagine coffee hour is similar to indoor dining. Is that a good idea right now?
It is similar to indoor dining. And, you know, I think, again, encouraging as many people to be boosted and vaccinated is a good idea. It's not zero risk. I think you have to take that into consideration. If it's a relatively nice day and you could have coffee hour outdoors, that's a safer choice too. So I wouldn't say it's absolutely a bad idea or a good idea. I think it really depends on the decisions the congregation makes. It is a surge. I don't know if I said this, but what we're hoping is, based on what we saw in South Africa and England and New York, that the surge will start coming down. So it may just be a few more weeks. So another way of looking at it is, you know, can you dial back, or can you decide what are the things that are most important to the life of the congregation, and just focus on those things and not do the extras for a couple of weeks and see where we are. That's another way to approach it.
Yeah, better safe than sorry, right? Pastor Joshua wants to know how we can tell if masks are counterfeits or not, or if they actually are meeting the standards.
I mean, this is a great question, and it's escaping me at the moment, so I'll make sure that I send it through. But there is a nonprofit that actually sources and vets some of these masks and does that. So I'll see if I can find the name of that. I just don't have it at my fingertips. But I think it's a really important question. You want to make sure you're getting reputable masks. So there are groups that have sprung up just for this very need. And so I'll see if I can locate any of those resources and send them through.
Do you have recommendations for good indoor air purifiers? Because it's cold out and people can't open the windows.
I know that I do not have. So I'll see whether I can track anything like that down. But you know, indoor air purifiers, I am not a industrial hygienist. There are people that specialize exactly in this. But it really depends. It's a certain number of cubic feet that it is good for. So really, you'd have to kind of know what's the space that you have, and then you know, how many air purifiers would you need. But I think this is also against the spectrum. Along the spectrum, we are not going to have absolute safety or absolute prevention of transmission if we are living our lives. And you know, I also want to say, we saw how much harm there was in like shutting everything down. And I know you all were so instrumental in keeping people going and trying to be creative and pivot and keep that sense of connection. So the mental health costs and the public health costs in that direction are also very, very costly, very expensive. So it's always a balance. So, you know, it's tough, but again, I think it's like taking into account everything that you value and trying to figure that out.
From a harm reduction standpoint, are there things that are safer in terms of communion? Some people put it together by hand and then wait a certain amount of time, or like they put it out the night before. Other people buy prepackaged kits that are like vacuum sealed. Do you have thoughts from a like harm reduction standpoint?
I am not so much worried. Good hand hygiene. So whoever's preparing, you know, the elements is doing good hand hygiene, but I'm sure they were doing that before. I don't think there's any necessity in leaving it out for 24 hours. I have seen the kits; those are, you know, another option. But again, I'm not so much worried about transmission from the elements per se. You know, I think that if people are taking communion or drinking the wine or the grape juice from the same chalice, that may be something that we don't want to do during this time. But I think aside from that, the principle is, what could I do that has people like having their mask down and so be able to do it as quickly as possible and put the mask back up is probably what we would say if congregations are masking. But this idea of limiting the amount of time that people are eating or drinking together indoors is probably a good one.
How about the isolation period after an exposure?
Thank you so much. Yes, and so what's happened? There's been a lot of change. It's confusing. And so let me see if I can just give the general guidance very briefly. There is a difference between what the national CDC recommendations are and the state is. And we all have to follow the state, including all of us health officers. We cannot be any less strict than the state, if that makes sense. We can be stricter in our area, but we can't be looser. So the state has said that if you test positive for COVID-19, you can stop your isolation on day 6 after your positive test or after your symptoms start if you have a negative test on day 5. So we recommend a rapid test for that because the PCRs can stay positive for longer. If you can't get a test, which many of us can't right now, you continue through day 10 and then you can stop your isolation. For quarantine, isolation means that you've tested positive. Quarantine means I've been in contact with someone else who tested positive, and now I'm at higher risk for developing COVID-19 myself. And so I need to be a little bit more cautious. This is where being up to date and boosted is super helpful. So if you are up to date on your vaccination, meaning you've gotten your primary vaccine and you're boosted, you don't need to quarantine. You just need to really watch and see, am I developing any symptoms? And if you are, you immediately want to isolate and test because you're higher risk having been exposed to someone. If you have gotten your primary series but are not boosted, in some settings, you can continue to work, but you have to wear a well-fitting mask. And actually for all of this, even if you don't have to quarantine, you should make sure you're wearing a good mask around others because you're in that period where you could potentially become positive. If you are not vaccinated, not boosted, then you, again, should be isolating for 5 days and getting a test and then wearing your mask for that whole period of time and not going anywhere. So basically it's almost the same as isolating if you are not vaccinated at all. Mm-hmm. So hopefully another incentive to go and get vaccinated and boosted so you don't have that. More and more of us are going to come in contact. You may probably have already experienced it, knowing someone or being a contact to someone else, unfortunately, who is tested positive. So that's where we are with that for now. There are other rules for healthcare workers and others, but that's the general population. And stay tuned. It could change because we have to keep society going. And as we learn more about the severity and hopefully we see that it's safe to do so, we'll probably see that isolation and quarantine guidance becomes even smaller.
A sentence that is sometimes said in church communities is, we've all been vaccinated, so we can all take our masks off for this meeting. Is that scientifically based or just a faithful hope that people?
Well, it was what we said too in San Francisco before Omicron. Mm-hmm. And what we said is that if we had a rule that said, everyone has to wear a mask indoors, except if you're in a stable group of people, like, so say a religious study group or some other group, a choir group that gets together and it's the same group of people and had their primary vaccine, we said you could remove the mask. And then Omicron changes that because it decreases the vaccine efficacy for infection kind of so far, not to zero, but low enough down that just those 2 doses is not enough. So if you're going to do something like that, the smartest thing would be to encourage everyone in that group to be vaccinated and get their booster. It's the best thing for their individual health, but that's the safest thing for the group as well. But right now, the state overall does not have exceptions for removing masks in most of those settings. There may be an exception for religious groups. So it's just something to be cautious of and aware of. That what was perfectly fine before. It's not that it was wrong before. It's just that the sands have shifted with Omicron, and now it's less safe than it was before.
Yeah, and maybe give it a sec until we have more science, right?
It could be good to do, and I know that people hate the masks and you can't see people's expressions and kind of be in community with people in the same way. But I know it's a sacrifice and really appreciate, again, you all lead the way in caring for neighbors and caring for each other. So I am always inspired by the work of faith communities like yours in actually living out some of the tenets of the faith, whether it's Christianity or Buddhism or Islam. And I think caring for each other is a part of so many. Judaism, caring for each other is so important.
I think one of the major needs in our community is for people to be able to see lips because of hearing issues and particularly age. And so I think that's part of the concern, is to want to be able to have everyone in community.
Exactly.
But to work that out. Yeah.
And that is a very important consideration. And that's where I would say, well, maybe we need to think about, is everyone as boosted as possible in this setting? And, if there is an ability for some folks to test and then have their masks off, those are the designated people that will have their masks off to help communicate. All of those considerations are important. I think what you're hearing is even though I'm the health officer in San Francisco, I don't have all the answers. I think there are no absolutes. There are just trade-offs, and there are just ways in which we try to do the best we can to attune to all of the needs of the people, of our groups and our families and ourselves. So the way you're thinking about it is exactly right.
Well, thank you. I very much appreciate your time. The windows behind me are something that my children and I have been doing throughout COVID. We need a couple more strings, but each string represents 1,000 people who have died from COVID. And they're intentionally rainbow colored to remind people about the disproportionate number of BIPOC individuals who are affected by this disease. And so we'll work on getting it more up to date with the current numbers. We got a little behind over the Christmas holiday. But thank you for the work that you do, both you personally and Nika here on this, but also all of the folk who work in the Department of Public Health and the Department of Emergency Management, who have been at the forefront of guidance on this. I'm really appreciative that you took this time with us, and know that our almost 180 congregations will be praying for you and sending out well wishes, or whatever the best way is for you to know that we care about you and are rooting for you, and are so ever grateful for all the work that you all are up to.
Oh, thank you. Thank you so much. That's a blessing to hear that. And I very much appreciate all the good wishes. And yes, I join you in thinking good thoughts and prayers for all of us and for our community. So thank you so much.
And thank you to everyone who's watching and tuning in, particularly those who are trying to keep their communities and faith communities safe. You are in my prayers as well. And if you have questions that you would like lifted up, you can continue to put them here in the direct messages, or you can contact us at the Synod office, and we will send out the links. Thank you again.